So for those of you that just joined us online, welcome. You do have the option of listening to this morning's presentation in French. You should have an interpretation tool at the bottom of your screen, and you can toggle that interpretation tool to French, and you will hear our lovely interpreter, Alex, throughout today's presentation in French. And we'll give it just a couple more minutes before we get started with our first session on Saturday as part of the virtual Defeat Duchenne Family Forum, presented by PTC Therapeutics and in partnership with BC Children's Hospital. So just a few more people joining us online. Welcome. I encourage everyone just to make sure also that you're hearing everything nice and loud and clear. You have your audio settings on the bottom left-hand corner of your screen. You have a little up arrow near those audio settings, and then you can toggle around and make sure that your speakers are working okay. Wonderful, some more people online, welcome, thank you so much. We have a packed agenda for this first session this morning, but please be reminded that if the presenters don't get through all their material, or if you do have any questions that aren't answered during this morning's presentation, we do have the coffee breaks right after. So this session is going to be about 40 minutes. Again, it's going to be information heavy, but then you have the opportunity to go into those coffee break rooms where you have the chance to meet one-on-one with today's panelists and have conversation and learn a little bit more about the topic that they came to speak about today and ask any questions that you might have. Wonderful, some more people, welcome. We'll just give it 2 more minutes. We're going to start right on time because we do have a full 40-minute agenda for this first session of the virtual Defeat Duchenne Family Forum. I hope everyone was able to get into Whova okay this morning. If you joined us last night, you noticed that not only are we logging into Whova to access all of the amazing engagement features, but when you do click into a session, it does open you up to a new screen that is Zoom. So while we're using Whova as our event platform, we have Zoom enabled within it to give that same functionality that I think most of us are quite used to by now. After 8 months of being in the pandemic, that Zoom has become our best friend. And so while you have the features in the back end on Whova to do the chat, to get to know the speakers, to do the direct messaging, put any questions, share helpful resources, each of the sessions that you click into will open up a new Zoom window for you. So I hope everyone's getting a little bit more comfortable with that format as we start today's session. Okay, so a few more people have joined us online. Thank you so much. It is gone 1 o'clock Eastern and 10 a.m. Pacific time, so we will get started. We have a full first session this morning. So I just want to welcome and thank everyone for joining the virtual Defeat Duchenne Family Forum presented by PTC Therapeutics and in partnership with BC Children's Hospital. I'm first going to turn it over to our Director of Strategic Partnerships, Rick Moss, who has organized this amazing event for us. So Rick, over to you.
Well, thank you, Rochelle. It's great to be here, and I want to thank everyone who's joining us this morning or this afternoon, again, depending on where you're coming from. In pulling this together, I just wanted to share how we really did this. We took the input from the families prior to this event. We asked them what was important to them. Clearly, the message that we got back was they wanted to be able to access the experts, the people you're going to hear from today and tomorrow, and the professionals. They wanted to have time to ask them questions about their own situation with their son. And so we've tried our very best to accommodate that in the format that we're using over the weekend. We've gathered those specialists, researchers, and clinicians from across BC, Canada, and even the US today. So the format for today, as you will hear presentations from these experts, followed by what we're calling coffee breaks that Rochelle referenced, an informal segment after each presentation for questions from the families and discussions with these experts. Into the agenda for today, I first of all want to specifically thank our sponsors for who made this possible. The registration, as you know, is free for everyone for this event, and it's only because of the generosity of the sponsors who were so kind in helping us put on this event. Our presenting sponsor, PTC Therapeutics, our silver sponsors, Atel Pharmaco and Pfizer, our gold sponsors, Sarepta, and our bronze sponsors, Catabasis, Roche, Audentis Therapeutics, and Solid Biosciences. Thank you all very, very much for your participation. So now to the day. Today, we are looking at session 1, how to prepare for the future. We're going to be talking about heart and lung health, plus what to expect at your clinic appointments with your cardiologist and respirologist. The experts that we've gathered are absolutely terrific, and I know you're going to be very engaged in their presentations. You'll then have a coffee break with Dr. Derek Human, a cardiologist, Dr. Jeremy Rhode, an adult respirologist, coffee break with Dr. Marie Wright, a pediatric respirologist. Second session is going to be how to prepare for the future. Segment 2, focusing on what to expect and how to manage bone and joint care, hormones, growth, and puberty. Coffee break will be with Dr. Daniel Metzger, an endocrinologist, and a coffee break with Christopher Riley, orthopedics. So those are going to be great and very, very informative sessions. Then we move on to innovative therapies, the first session there. Again, we want to thank Dr. Selby for hosting these sessions today. She's just been terrific. I can't say enough about her contribution. But we'll be learning about a mutation-specific approach to restoring dystrophin called exon skipping, and a mutation-independent approaches to replacing dystrophin with a mini version of the dystrophin called gene therapy. And the experts that we've called upon this afternoon and this morning for this are Dr. Craig Campbell, a pediatric neurologist, and Dr. Mendel, from Nationwide Children's Hospital in Columbus, Ohio, one of the world leaders in gene therapy and research. The format continues then with Innovative Therapy Session 2. We'll learn about small molecules, the therapeutic approaches, and what we call downstream effects, and include fibrosis, inflammation, muscle membrane integrity, and muscle wasting. We'll also discuss future research direction in Duchenne. And for that, we have Dr. Catherine Selby, our pediatric neurologist, and Dr. Jim Dowling, pediatric neurologist. Living a Healthy Lifestyle, Session 1 is following that. And we'll learn about physiotherapy and nutrition with coffee breaks with Alex Spritis, a dietitian, and Fatima, who is also a physiotherapist. The Living and Healthy Lifestyle Session 2 will focus on recreational therapies, an important component for the boys, and occupational therapy. Discussing the strategies to keep you active and safe. And we're fortunate to have Patricia Mortensen join us, an occupational therapist, and Sherry Steele from Sunny Hill Health Center, a recreational therapist. And then, of course, to wrap up the day, if you aren't exhausted at that point, we have a little after party, as we call it. Rochelle will be telling you more about that. You hear more about that throughout the day, but we hope that you'll join us late afternoon or evening, depending again on where you are. Rochelle, thank you, and back to you.
Perfect. Thanks, Rick. So just a couple housekeeping notes as we go along today. The Q&A is enabled on Zoom. So you'll see that Q&A option at the very bottom. We have a very full agenda, and the coffee breaks right after this session are more for those questions and answers, but feel free to put it into the Q&A in Zoom. We will transfer those questions into the coffee breaks with the specialists. We'll also take those questions that you posed during today's session and put them into the session Q&A area on Whova. So I'll just mention where that is, just right over here. If you're on the desktop version, there's a session Q&A. Feel free to post questions before any sessions or after any sessions. All the speakers are going to kind of just be checking that session Q&A throughout the weekend and helping to answer those questions as we go along. So again, you have the Q&A at the very bottom to pose any questions during the session, but then also during the coffee breaks to have that one-on-one question time. I mentioned the interpretation earlier. We have our interpreter on the line. So I know quite a few people have joined us since I mentioned that. And you can turn on the interpretation tool at the bottom of your screen. Just toggle that to the French option. I also mentioned the audio settings very earlier this morning, and you have an option to just test out your speakers just to make sure you can hear everything nice and loud and clear for you. And so I will now turn it over to Dr. Catherine Selby, a pediatric neurologist at BC Children's Hospital, and she is going to host today's session. Over to you, Dr. Selby.
Thank you very much. And first of all, I just want to thank everybody for joining us this morning. Good morning. Here in Vancouver, it's nice and sunny and not raining this morning, so that's great. And I hope that wherever you are, that it is also good for you. We've got a really exciting morning. I'm going to give a little bit of an overview about DMD, and then I'm going to be handing over to this great team we've got this morning of cardiology and respirology. And I really look forward to sharing that with you. And I'm going to try and share my screen with you right now. And hopefully everybody can see my screen and hear me. So I want to give a little bit of an overview of what happens in the journey of individuals with Duchenne muscular dystrophy, and especially during this COVID time where what the meeting that we're having today is really very different from the one that we would normally have, where we can actually mix and mingle with each other. And so the aim of this brief presentation is really to give you a brief overview of DMD and to talk about the family and patient journey and our ongoing commitment to work with you to improve the health and well-being of children and families with DMD. These are my disclosures. So the clinical journey in Duchenne, it usually starts early in life and is often not recognized as early as we'd like it to be. The incidence of boys with DMD is 1 in 3,800 to 6,200 of live male births. And as you all know, it's an X-linked disorder with a mutation of the dystrophin gene. And this is helping us to be able to, our understanding of this is helping us to be able to look for new treatments and potential cures. At this point, as you know, there is no cure, but what has been so exciting over these last few years is both improvement in health and improvement in understanding of the disease, which is leading to new therapeutic options. There's progressive weakness, and even by the age of 3 years of age, it's impacting the daily life of our kids. There may be challenges with school and learning. There are progressive difficulties in physical mobility, and it's a multi-system disorder that involves the heart, respiratory function, bone health, growth, and the quality of life. And when we try to engage with our community partners, both in health and education, to be able to notice those individuals who have delay in their motor milestones or an unusual gait or speech delay, to be able to go ahead and check the CK so that we can make an early diagnosis. The treatment, as you know, is complex, and it's really important to be involved with the standards of care and to have that multidisciplinary team, because it is all so important. As you know, we're very involved with steroids. We don't like their side effects, and we hope that there may be newer treatments to be able to reduce some of the side effects of that. Vitamin D is really important. Today, we'll be discussing with orthopedic colleagues with cardiology and respirology and with endocrinology to look at some of these aspects of care in DMD. Nutrition, extremely important, as well as ongoing input with physio and occupational therapy. The use of orthotics, the use of exercise and recreation and having fun and making sure that the children that we're looking after are able to participate with or without adapted function for being able to do the things that they love. Looking after the mental health, both of the child and the family, and getting involved where families wish to in various research and trials, because this is our way forward to be able to look at what we can do to help in the lives, well-being, and eventual cure of this disorder. And involving registries where we're able to look at real world evidence, where we're able to get countries trial ready to be able to allow our children to be part of these exciting new discoveries. This is the pipeline that we have at present, and we can see that the problems that the lack of dystrophin causes might just lead to the solutions we need to help the children in multiple different ways. And going through from preclinical to phase 1, 2, and 3 studies, and then going into approved therapy are the things that we're seeing happening on a very regular basis now. As we know, there are various stages in DMD, from diagnosis through that early ambulatory to late ambulatory stage, and then the non-ambulatory phase. And that has certainly been improving as we go through things, but not enough for all of us. There's still delay in diagnosis, so that from the length of the symptom onset to somebody doing a creatinine kinase is still too long. and then getting molecular genetics done. And by delaying the diagnosis of DMD, it impacts our standards of care, our ability to give information to families, and recruitment into clinical trials. So we want to try to help in reducing that period of time. There are also a lot of things happening across the country. Also, thanks to Jess's journey, the Canadian Neuromuscular Disease Registry got started many years ago. There's been involvement of the Canadian Pediatric Neuromuscular Group and Muscular Dystrophy Canada. In the last year, there's been the development under Dr. Lochmuller of the Neuromuscular Disease for Canada network, where he's really trying to bring all of these things together. We're working under a CIHR grant and really wanting to get patient engagement, having clinical trial networks, and involving scientists, clinicians, different parent groups, patients themselves, and really engaging all stakeholders in neuromuscular diseases to really make this work for Canadians. So lots of exciting things happening in Canada. And I think this really leads to the future. There's lots of hope. And on the left-hand side of the slide, you can see some of the decisions that children have decided how we're also going to get out of our pandemic, with drinking lots of tea, which I can certainly adhere to, washing our hands lots, and coughing in our arms, and definitely working together towards a good future for our children and families with DMD. And thank you very much. I am going to introduce to you Dr. Human, and it's really my great pleasure to be working with such a great team of physicians. Dr. Human is a professor in the Department of Pediatrics at UBC. He's a cardiologist and has developed partnership programs in BC, is really involved with the long-term care of patients with neuromuscular diseases, with cardiac transplantation, is really also involved in continuing medical education, and has run lots of programs in pediatric cardiology for our residents and for other learners. And so it's with great pleasure. I've worked with Dr. Human for many years in the neuromuscular clinic, and I look forward to handing over to him now. Thank you.
Good morning, everybody, and thank you, Kathy, for that introduction, and thank you for inviting me to be part of this meeting. And this is certainly a different experience for these different times. I have always found these types of family and health professional conferences to be uniquely satisfying in being able to share our knowledge and our experiences together. And I hope we can still do this even in this virtual world. So these are uncertain times, and as I began to think about the cardiologist's role in preparing for the future, I realized that a rather infamous quote was really a very good summary of where we stand. There are the known knowns. These are the things that we know we know. We also know that there are known unknowns, and that is to say we know that there are some things we just do not know, but there are also the unknown unknowns. Those things we don't even know that we don't even know. So this is the sort of three areas that I thought I would talk about the heart. Things we know we know. Well, we know that mutations in dystrophin are really important. And we know that dystrophin, seen here, is that important anchor that holds together the lining of the individual muscle fiber, the sarcolemma, to the actin, the muscle contractile apparatus, which actually makes the muscle work. We know that these mutations affect both skeletal and cardiac muscle. And we know that almost everyone with DMD will eventually show a decrease in their heart function. Things we know, well, we know that steroids, whether it's the deflazacort, whether it's prednisolone, they improve survival. And that improved survival is strongly associated with freedom from ventricular dysfunction. And this graph here shows at the start of the course of steroids for those with the dark line here, those who are treated with steroids. And we can see that within about 2 years of follow-up, those who are not receiving steroids, there is evidence of a decline in their ventricular function. And this is progressive over the 5 years or so of this graph. And there have been a number of studies to show that steroids protects the function of the heart and prevents progressive change for the worse. So things we know. We also know that other medical treatments will improve heart function. And these are the standard heart function drugs, which we'll touch on a bit in the future. This was a study that looked at a whole variety of muscular dystrophy patients, including the dystrophinopathies, but also other facioscapular muscular dystrophy and so forth. And overall, all of them showed an improvement. This is the measurement of the thing called your left ventricular ejection fraction. And that left ventricular ejection fraction should normally be around about 50 to 55%. And we can see that in all of these conditions, it was low at the start. And after 3 years of follow-up, receiving different and uncontrolled types of treatment, however, they all showed a degree of improvement. And finally, we know that medical imaging is absolutely crucial to assess heart function. There is no value in waiting for obvious signs of heart failure to occur in Duchenne muscular dystrophy. We need to be looking aggressively and proactively for subtle changes. And the tools there are the echocardiogram, which I'm sure everyone is familiar with. The advantage being it's relatively easy to do, assuming that you have the skilled technicians and cardiologists to interpret it. And the most important thing is it's safe, it's easy to repeat, and therefore it's an ideal way to serially follow how people are doing. Cardiac magnetic resonance, or CMR, is becoming more and more important. And the value there is that as the children get older, the echo often becomes less reliable because of changes in the shape of the chest wall, maybe that gain in weight that we see so often with steroid therapy. So echo gets harder to do in a sufficiently accurate way. And then magnetic resonance comes to our aid. The problem with magnetic resonance being that it takes much longer to do. It's a much more cumbersome process. It's much harder to do repeated studies every 6 months or so. Given the shortage of MRI machines. So those things we know. What about the things we know that we don't know? So why does dystrophin actually cause muscle damage? That sequence of events, especially as it affects the heart, is not really clearly defined. The most popular theory is that it's mechanical disruption, that when we don't have this cable tying together the sarcolemma and the actin itself, that causes progressive destruction of the heart muscle cells, and then they begin to die and they create a scar tissue. And the sequence of what guides that, and also the role of all of these other complexes, which are called part of the dystroglycan complex, are really unknown. We don't yet know, will repairing or replacing dystrophin, will it treat heart function that's already gone down? Will it in fact maintain normal heart function? These are all parts of the exciting future. And the other thing we don't understand is, well, why is this decrease in heart function so variable over time? Some boys have obvious changes by the age of 9 or 10. Others have no evident change even a decade later. The other things we don't know is, well, when should we actually start medication? When does the heart function need to be addressed? What medication should we use? And as you see here, there's a whole soup of different drugs which are used in the treatment of heart failure. And in what order and in what dose? And even what is the best way to identify and monitor heart function? Well, how am I going to manage these known unknowns? So the one thing which is very helpful is serial echocardiography. The same child imaged every 6, 12, 24 months, making sure that very subtle changes we can become aware of. And here's where we use these advanced echo techniques, things called tissue Doppler imaging, myocardial strain imaging. These show us those subtle changes of heart muscle scarring occurring long before the overall measurement of heart function, that thing called the ejection fraction, begins to go down. And then we have access to CMR if the echo becomes unreliable. And that too has been shown to give a very accurate measure of how much scar tissue is there, is it progressing with time, and can that be reversed. We need to discuss indications for treatment of the heart muscle, certainly as soon as there's any change on our imaging, and always by 12 years of age. But then what are we going to introduce? So the buzzword for the treatment of heart failure is guideline-directed medical therapy. Well, do we have that in terms of our population with DMD? And these medications are what's called the neurohormonal antagonists. These are the mainstay of therapy. And each of this family of drugs is trying to damp down the actions of different parts of all those complex endocrine and neurological signaling within the body. The renin-angiotensin system, the beta-adrenergic system, we're going to want to block them. The mineralocorticoid receptor antagonist, we want to block that. And the newest one in the armamentarium is neprilysin inhibitors. And there is an ongoing study at the moment to try this medication in children. It's been accepted in the adult world already. So guideline-directed medical therapy for the treatment of heart failure in adults is guided by these trials involving thousands of adult patients with heart failure. And results from these trials show a definite survival benefit with all of these above therapies. And for a patient to be a status 1 GDMT, which is what you want as an adult heart failure specialist, your patients should be receiving treatment consistent with the strategy described in the landmark trial that demonstrated the survival benefit. Well, where does that leave us with our population? For our population, there is no landmark trial. There are no target doses defined for our patients, and there is no large-scale study to demonstrate which medications really do have the most benefit. So what can we do? Well, we'll adopt strategies from other expert groups. And this is the statement that came out from the Canadian Society of Cardiology and addressing, well, what medication should be used in heart failure in general. And as you can see, we're going to use an ACE inhibitor, a beta blocker, an aldosterone antagonist, and introducing them in the stepwise manner. But as I say, there is no clear indication at which point these drugs should be introduced. And what about the unknown unknowns? Molecular research and the intracellular environment, how all of these molecules interact together is the most exciting part for the future. And I look forward to being a part of those innovative therapy sessions in the future. So thank you for the opportunity to speak to everybody. I think there is, as Kathy highlighted as well, great hope for the future. The major institutions such as American Heart Institute, the National Institute of Heart Health and Lung have focused on cardiac issues in Duchenne dystrophy, and their statement of this recent review article, well, 5 years ago, recent review article, really addresses all the value of animal models, clinical research, and collaboration between the patients and families and medical research. So thank you again, and I'm happy to take questions in the breakout session ahead.
Thank you very much, Dr. Human, for a really beautiful overview of both the reality and hopefully the future of what's going to be happening in the cardiac care of children with Duchenne muscular dystrophy. And certainly if everybody could keep their questions so that you'll be able to ask Dr. Human those questions in the breakout session. I'd now like to introduce Dr. Rhode. And so I've been working with Dr. Rhode over many years, and he is a professor in medicine at UBC and a respirologist at Vancouver Hospital in UBC. He's the chair of the Canadian Thoracic Society and Research Committee and medical director of the PROP, the Provincial Respiratory Outreach Program. and the Vancouver Hospital Lung Function Laboratory. And he has special interest in neuromuscular diseases and in sleep disordered breathing, and has been incredibly instrumental in the ongoing engagement and management of respiratory care in our older boys and young adults with Duchenne muscular dystrophy. So thank you very much for joining us today, Dr. Rhodes. I'm going to hand over to you.
Thank you, Kathy. It's a pleasure to be here, and always nice to talk to the group. We usually have our small group in Vancouver, but it's I guess an advantage of this is we now have a big group, which is I can see we're at the end of my talk here. There we go. Can everybody see and hear me now? I think should be okay. So
Yep, we're all good.
Okay, great. So it's basically breathing, and breathing, as we know, is important. I think Dr. Human has outlined the challenges in the cardiac world. In the respiratory world, we've been benefited from technology largely to improve how we manage our patients. And I'm going to get right into what we've got in terms of guidelines. As Dr. Human was insinuating, it's difficult to do large studies in muscular dystrophy patients, although it's getting much better. So we didn't have a lot of evidence to support our observations. So basically, Canada, Australia, Europe, we all got together probably about 10 years ago and put together what we thought were useful guidelines for how we would manage people's breathing difficulties with muscular dystrophy. This one is the one for Canada, and I was fortunate enough to be involved in it. And Duchenne's muscular dystrophy was a big component of those guidelines. And we basically, by that time, had enough evidence to indicate that there was definitely a survival benefit from assisting breathing, and we just had the technology available to do it. And I think it was beyond the need for a randomized controlled trial. I don't think anybody wanted to be randomized to not getting ventilators. So we're pretty convinced that they help with what we need to do in life. And the functions of our lungs are to bring in the oxygen and particularly get rid of the carbon dioxide. And that's a vital function of the pump that pumps air in and out of our lungs. When the function becomes diminished, it can be assisted by mechanical ventilation. So the question that arises, when do we begin mechanical ventilation? So our little group got together, and this is a group from across Canada, and came up with these recommendations that we follow patients in terms of their symptoms, because daytime sleepiness and morning headache do become features if you start to have your breathing affected. Your breathing muscles largely become noticeable when they're not working properly because of how it impacts your breathing when you're sleeping. And the result is retained carbon dioxide at some point in the evolution of the muscle weakness. And so it's intervening at that point. And so one of the things we ask for are symptoms. Are you feeling those symptoms of headache or lethargy in the mornings? And then we also monitor your lung capacity. And this is the way we do it. We have you blow as hard as you can until all the air has come out of your lung, and we measure the volume. And from that, we get an idea where the strength of your lungs and your breathing muscles. And we can sort of that helps us to figure out when we need to intervene in terms of supporting your breathing. So the recommendations for treatment are when the carbon dioxide level is building up too much, we should definitely start assisting breathing. And I've called it NIV here, which is non-invasive ventilation. And that's certainly the preferred way initially. Sometimes we have to proceed to invasive ventilation, but essentially it's non-invasive ventilation. It's given at nighttime because of this problem that I was alluding to with difficulty with your breathing at night. At night, your drive to breathe decreases. And so you tend not to use your muscles as strongly as you could to keep carbon dioxide normalized. So it's the nighttime when we introduce the breathing devices. And basically, we know we can increase the survival based on case control studies. Like I said, there's no randomized control trial. And what we found is the quality of life, when it's maintained with non-invasive ventilation like this or invasive ventilation, is quite high. Particularly in many domains that we evaluate patients with, the mental health, with social functioning, social relationships, the quality of life is excellent when we can sustain the clarity of mind with the ventilator assist. And many patients can be managed with non-invasive ventilation, with mouthpiece ventilation. So the other thing I'm going to allude to is at the bottom there, when we support breathing, we also have to be aware that the expiratory muscles are weakened, and they're very important in coughing and clearing secretions. So as part of the initiation of support to breathing, we also are very aware of the time when we need to initiate help with clearing secretions and coughing. So you'll find these peak cough flow rates have come into our measurements, and having you exhale as fast as you can, it gives us an idea of how good you're able to clear secretions. So where did all this come from? I'm just going to tell you a little bit of history about, in case you didn't know, this is where the pyramids came from. They dropped in out of the blue. Well, ventilation began with the polio epidemics in the 50s, and there were these big iron lungs that created a negative pressure inside the lung, and your head poked out the end, and that way you were able to support breathing. But you can see they're quite cumbersome. And during the polio epidemic, they had wards that were filled with these, and the Queen in England got quite upset about this and said, we need to come up with a better way of ventilating people. And some anesthetists came up with, this is the first positive pressure device, with the idea, instead of drawing the air into your lungs with that big negative pressure cylinder, this actually pushes air into your lungs. And that's one of the first ones. And then we can see now that things have evolved quite significantly. You can see an array of devices now, which are very portable. You can put them on your wheelchairs, and so it gives lots of freedom of mobility. And we also have devices which are very helpful down here at assisting cough as well. So there are devices when the cough and the expiratory function of the muscles is reduced to help with clearing secretions. And then, having said that, the interfaces are very important. And this largely evolved when we started treating sleep apnea with nasal CPAP. They said, well, why don't we use the same mask to ventilate people? And it's Cyelastic and Velcro really help with this. And you can see there's nasal pillows, which are quite small and non-intrusive. And if you're a bit claustrophobic, those are good. And there are full face masks and nasal masks. And as you can see, a mouthpiece ventilator here, which is attached to a gooseneck, allows you to have a ventilator on the back of the wheelchair and have your breathing supported. I always relate this to, it's a bit like smoking a cigar, but we don't like smoking in my field, but it's a bit like taking breaths from a cigar. And this is the advent of Cyelastic, which really allowed us to maintain good seals so that we could assist people's breathing with a device that was comfortable and a material that was comfortable. And Velcro came along because before this, the non-invasive mask had red rubber on here, which is very firm and not very giving, and belt buckles here to adjust the mask. So all this technology, along with the ventilators, improved our ability to do non-invasive ventilation. But having said about non-invasive ventilation, it's very important. We need to assist with coughing and airway clearance, but we also use the same techniques for lung volume recruitment. And we're starting to recognize now that the chest walls, your rib cage, and even the diaphragm to a degree, can get stiffer over time. And so maintaining the flexibility in those structures is very important. And by doing lung volume recruitment, we can maintain that flexibility and make it easier for the muscles to expand the lungs. And this is a simple device for cough assist, or can be used for lung volume recruitment, just an ambubag with a one-way valve. And with this, you can inflate the lungs comfortably, not too much, you get a little bit dizzy, but enough to get enough air in the lungs. And then when you exhale, you get a nice volume of air. And then this technique, even when you're not using it for cough assist, you can use it to stretch the lungs and do this lung volume recruitment, which improves the compliance of the system. So here's somebody with a mechanical cough assist. So that's not the AmbuBag that I just showed you, but this is the mechanical one. And these are quite available, well, fairly available now. They're not cheap, but they are. In British Columbia, we have the Provincial Respiratory Outreach Program, which does have a number of these. And they can really assist with coughing and with doing lung volume recruitment. And you can also do breath stacking and improve the compliance of the chest wall with spontaneous breathing by just adding breaths and not letting them out. Or you can get assistance from your ventilator to do that. So as I mentioned, in British Columbia, we're fortunate, and I think in other provinces, there are provincially funded programs that will provide a lot of this equipment to allow non-invasive ventilation, invasive ventilation, or lung volume recruitment and cough assist devices. In British Columbia, you can see the Provincial Respiratory Outreach Program. We have a number of patients with different conditions, and muscular dystrophy is certainly a very important, significant component of the Provincial Respiratory Outreach Program's activity. And this is one of our satisfied clients, and you can see he's got his ventilator here at the bedside. He's got one on the bed too, and he's got a mouthpiece ventilator there. And I think there's a cough assist device there somewhere here. It's in the back. So it's all that makes you functioning from the respiratory point of view, keeps everything going smoothly. And then the mobility allows you to go around and visit places. Not right now, but in the future, we can look forward to doing some of that. Thank you very much for your attention. I'm happy to answer questions at the coffee break.
Thank you very much, Dr. Rhode, for giving us a beautiful view of the long-term respiratory care in our boys with DMD. And we're going to backtrack a little bit now to go to the pediatric side of the respiratory care. And people will be able to ask Dr. Rhode later on for any questions with respect to the adult side of things. I'm now going to welcome Dr. Marie Wright, who is one of our new pediatric respirologists at BC Children and clinical assistant professor in the Department of Pediatrics at UBC. And she has a keen interest in neuromuscular diseases and in clinical research, and also in studying rare diseases in the lungs and airways of children and investigating different patterns and determinants of their health. She also runs the pediatric home ventilation program and works alongside the nurses and physios to be able to do this. And she is going to talk to us this morning about the pediatric care in neuromuscular diseases and in particular in DMD. Thanks very much, Marie.
Thanks, Kathy, for the introduction, and to Jesse's Jenny for inviting me today. And I should say thanks to Dr. Rhode as well, because he's given a fantastic introduction into respiratory problems and has probably cut down my presentation quite a lot because I don't want to give you duplicate information. So what I'll try and focus on then is the kind of main differences between respiratory health and what we do in the pediatric world compared to when you're a bit older and you transition through to adult care. So just to give an overview of what I'd like to talk about, again, lots of this covered by Dr. Rhode already, but I'll give a brief overview of how the lungs are actually affected in boys with DMD. And I think of this in quite simple terms, in terms of how the breathing is affected, how the coughing is affected, and I'll touch on swallowing as well, because I think that really is important to lung health. I'm going to tell you in the pediatric world how and when we test for these problems, and a bit about the available treatments and when we tend to start them. And I don't have anything to disclose. So you've already heard from Dr. Rhode that the main purpose of the lungs is to bring oxygen into the body and to blow off a waste gas called carbon dioxide. And for the lungs to be able to do this effectively, the lung or respiratory muscles need to work well. And we've all got muscles, as you can see in this top picture, all the way around our chest, in between our ribs and under our lungs as well. So just as the skeletal muscles get weak over time in DMD, unfortunately, the chest wall muscles do as well, and that can make our breathing and gas exchange less effective, and can also affect the strength of cough and mucus clearance, as we've already heard. I just want to highlight the swallowing muscles as well, because they can potentially become weak over time, and that can cause a problem whereby when we eat and drink, instead of the liquid going down the gullet into the stomach, some of it spills over into the windpipe and goes down into the lungs, causing a problem called aspiration, which can result in some inflammation and scarring in the lungs. So when we're thinking about lung health in the pediatric world, we think about how to stop that from happening as well. So again, you've heard about lots of these tests from Dr. Rhode, but I'm going to go quickly through the main tests we do in the pediatric respiratory world to monitor lung function and to detect these problems at an early stage. The first of them is lung function tests. The kind of terminology around lung function tests can be quite confusing because we call them lots of different things: spirometry, blowing test, PFTs. They're all pretty much the same. And as you've heard from Dr. Rhode, the main measure is the FVC, which really tells us how much air you can take in and blow out of your lungs, and is a really good kind of marker for how strong the respiratory muscles are. We can't do this in young children because it does require some sort of understanding and being able to follow a technique. But from when children are around 5-6 years of age, normally they're able to do this test quite nicely. And from then on, we would normally recommend monitoring lung function with blowing tests every sort of 6 to 12 months, depending on how the child is doing and what they have in terms of symptoms. The next test we tend to do fairly routinely is sleep studies, because as you've heard from Dr. Rhode, when we're asleep, our muscles, even in healthy state, become more relaxed, our breathing becomes a bit more shallow, and our gas exchange can be affected. So when you do have a problem with your breathing muscles, it tends to first show itself during sleep. So we've got a few different types of sleep studies we can use to try and pick up on these problems. The top study here, you can see this girl's got a lot of monitoring. She's got lots of stickies and cables here, there, and everywhere. And this is our sort of highest level of sleep study that we do in hospital, called a PSG. But there are more simple types of study that can actually be done at home, like the study at the test at the bottom of this page here, which just monitors oxygen levels. And it's normally your respiratory team, your respiratory pediatrician or physician who would direct what type of test is right for answering the question they have about your child. In the pediatric world, we don't normally do these tests at a very early stage. We normally wait until lung function tests suggest that the breathing muscles have become more weak, normally when your FVC hits around 50%, or if your child develops symptoms suggestive of a sleep problem like daytime headaches, poor energy levels, or things like snoring and pausing and breathing at nighttime, because DMD, as well as causing problems with your ventilation at night, also puts you at higher risk of sleep apnea. And the final type of tests we do quite a lot through my clinic are swallowing tests, just to check in as to how strong and effective the swallowing muscles are. This is normally overseen by an OT, who are really important parts of our team. And they look at things like a straightforward bedside swallowing assessment, where they might watch your child drinking liquids of different consistencies and watching them eat foods of different consistencies and seeing if they're showing any signs of choking or coughing or gurgling. Then we can do some tests that involve x-rays as well. We can do straightforward x-rays of the lungs to see if there's any evidence of aspiration or scarring. And we can do a test called a video fluoroscopy, where you actually drink, it doesn't taste as awful as it sounds, but you drink dyes of different thicknesses and then do serial x-rays to see if any of that dye is actually spilling over into the windpipe. And as well as all of these fancy tests, I think a really important part of respiratory assessment in kids with DMD is just talking about the sort of symptoms you're experiencing. And it's really great if you can come to your clinic appointments, whether it's with your neurologist or with your respiratory doctor, with a sort of checklist in mind as to whether your child has had any of these problems. So we should be routinely asking about whether they've had any chest infections recently and how long it takes them to fight those off, whether their cough is sounding nice and strong, or if it sounds like it might be becoming weaker, any problems with eating and drinking or drooling, and any nighttime symptoms as well. So when we pick up these problems, hopefully it's a nice early stage. What are we going to do about it? Let's have a quick chat about that. And Dr. Rhode's already given you a really in-depth, lovely historical view of respiratory support for children and young people with DMD. And the mainstay is still the same in pediatrics as well as the adult world. So CPAP and BiPAP are really the things that we tend to use. It's quite rare for children up to the age of 18 with DMD to need daytime support, so it's generally something we just give at night. And our variety of masks and interfaces are perhaps a little more funky than the ones you'll see in the adult world. So we have masks and headsets with patterns and things like that as well, because we really want our kids to sort of buy into the treatment and to really get involved and want to actually keep using CPAP or BiPAP on a nightly basis. We don't normally start these treatments until the lung function has dropped fairly significantly, or if the child has evidence from sleep studies or symptoms to suggest they're having problems with ventilation or sleep apnea. And in practice, that normally means it's kind of mid to late teens when we start thinking about introducing something like this. And we do actually have many kids with DMD who actually move on to the adult world without actually having to start these treatments in our centre. In terms of the parents here today, I think the one thing I wanted to flag from a paediatric perspective is that understandably kids don't always love it when you start them on CPAP or BiPAP, and wearing a mask at night time and the sensation of the pressure going through that mask can be quite challenging for them at first. So as a parent, I think my message would be that consistency, a positive approach, but a kind of consistent approach is really key, trying to get them used to wearing the mask every night as part of their bedtime routine and just persevering with it, because lots of kids don't love it at first. But as you heard from Dr. Rhode, it has such a potential for a positive impact on quality of life and maintaining good breathing function that it really is worth sticking with, and most kids do become used to it and feel better as a result of it over time. You've already heard lots about physiotherapy, and chest physio is an important part of management in the paediatric world as well, to keep the lungs clear from mucus. And it's something we normally introduce when the cough is starting to get weak or the lung function tests are showing a decline in muscle strength. We work very closely with physiotherapists in our clinic, and we take the opposite of a sort of one-size-fits-all approach and recognise that different children at different stages will benefit from different types of chest physio. And I've listed some of the techniques that we use here. Cough assists, I think, in children are used in lots of other places in Canada, but we don't tend to actually use them in my centre in Vancouver, and instead we tend to use a type of deep breathing physio that you do through your BiPAP mask. So it's similar in some ways and different in others. We call it BAMI, and we find that our families have really good results, and I'm happy to answer any questions about that later if anyone has any specifics. In terms of feeding support, again, most young people with DMD do actually maintain quite normal swallowing function whilst they're in the paediatric world, and swallowing muscles can become weaker later on, but it is something we test for. And if you do have symptoms of a swallowing problem or aspiration, or you're having recurrent chest infections and hospital admissions, it is something we look into. And again, we always get our OTs or our speech and language therapists on board because they're really experts in this area. And if they pick up a problem, they might recommend some interventions like thickening up your fluids so they're less likely to spill into the windpipe. Simple practical things like changing the type of cup you're drinking from or drinking from a straw. And if there's a significant severe problem with aspiration and pneumonias, there are some occasions where they might recommend feeding directly into the stomach through a gastrostomy or a G tube. Pretty rare in children, but it is something that we do have to think about on occasion. And just my last comment really is that there are a grab bag of other things that I think we do rely on and think about a lot in the paediatric world for keeping the lungs healthy. We recommend that all of our kids get the flu vaccine each winter, and their whole family as well, because if you do have weak respiratory muscles and you get a virus like the flu, it can make you more sick and potentially at risk of being admitted to hospital and needing respiratory support. So if you haven't done it already this year, I would recommend that. Being aware that kids can also get more sicker and are more prone to chest infections. So if your son develops a wet cough that they're not shaking off, or their breathing becomes more laboured, or they have a fever, getting them seen by a doctor at an early stage to consider whether they need antibiotics. We've already heard about all of the merits of steroids, so I'm not going to go into that anymore, other than to say that there's decent evidence that they preserve lung function and slow decline in young people and adults with DMD. Research, study drugs, there are loads of exciting things coming up, and we're obviously really hopeful in the respiratory world that the positive impact we see from these drugs on muscle strength in the arms and legs will translate to improved lung health as well, so watch this space. And finally, I think you've got a session later today about from one of the orthopedic doctors talking, I assume, about scoliosis management as well. So adolescents who have DMD can develop a curvature of their spine or a scoliosis over time, and this can impact on how effectively they cough and how well their lungs work. So seeing an expert in that area to discuss treatment of a scoliosis is something else that's important to lung health. So thanks very much for listening. I'm aware that we're probably over time already and people are heading to the coffee break, so I'm not going to go over these points again, but very happy to take any questions and chat with you all further. And just my last point I think I want to flag up is that in the respiratory world, we're part of a a bigger machine. The multidisciplinary team that we work with is so important. So thanks to all of our helpers.
Thank you very much, Marie, and the other people from this morning. Thank you, Dr. Human and Dr. Rhodes and Dr. Wright, for a really great overview, both in the cardiac and respiratory side of the journey that our kids go through, both in their early life and as they get older. And I thank you very much indeed for giving such comprehensive talks. And I'm going to hand over to Rochelle now, who's going to direct the traffic.
Thank you so much, everyone. And that was an amazing first session this morning. A lot of information shared. So thank you so much. I know everyone that's on the line right now, we're running a few minutes over time, but we are going to just push back the next session, the next how to prepare for the future session number 2. We'll push it back just by 10 minutes. So we have a good 15-20 minutes still in the coffee break. So we will end this session. All the specialists are going to go into their coffee break room, grab a cup of coffee and join them in there to help answer your questions. And we look forward to seeing you in those 3 coffee break rooms in a moment. Thank you, everyone. Bye-bye.